In today's video, we'll tackle two high-yield clinical scenarios often tested on exams. The first explores a malabsorptive disorder linked to chronic diarrhea, weight loss, and nutrient deficiencies. The second focuses on acute abdominal pain where history, physical examination, lab tests, and radiology all play a role in diagnosis. Together, these questions will sharpen your reasoning in differentiating similar presentations. A 22-year-old college student presents to her primary care physician with a 2-month history of bloating, frequent loose stools, and increasing fatigue. She has unintentionally lost 5 kilograms during this period despite no changes in diet or activity. She takes no medications and has no significant medical history. On examination, multiple pruritic erythematous papules are noted on the extensor surfaces of both knees. Upper endoscopy with a duodenal biopsy demonstrates blunted villi, crypt hyperplasia, and dense lymphocytic infiltration of the mucosa. If this condition remains untreated, which of the following complications or nutrient deficiencies is most likely to develop? The options given here are A. Hypercalcemia secondary to vitamin D deficiency, B. Macrocytic anemia secondary to vitamin B12 deficiency, C. Microcytic anemia secondary to iron deficiency, D. Nystagmus secondary to vitamin A deficiency, E. Perifollicular hemorrhages secondary to vitamin C deficiency. The correct option here would be C. Macrocytic anemia secondary to iron deficiency, and that is because this patient's symptoms of chronic diarrhea, weight loss, and fatigue, along with pruritic rash on extensor surfaces and a biopsy finding, are classic for celiac disease. This condition causes malabsorption in the proximal small intestine, which is usually the duodenum and jejunum. Iron is absorbed in this region, and iron deficiency is the most common nutritional consequence. Untreated celiac disease, therefore, most often results in microcytic hypochromic anemia. Let's have a look at why the other options are incorrect. Option A is incorrect because vitamin D absorption can be impaired in celiac disease because it is fat soluble, and this can lead to hypocalcemia and not hypercalcemia due to decreased intestinal calcium absorption. Patients may develop osteomalacia or osteoporosis, but hypercalcemia is not expected. And option B is incorrect because vitamin B12 absorption occurs in the terminal ileum and is most commonly impaired in conditions like Crohn's disease and not celiac disease. Although celiac disease may rarely affect the ileum, its primary impact is on the proximal small bowel, where iron and folate absorption occur. Therefore, iron deficiency anemia is far more typical than vitamin B12 deficiency in this setting. And option D is incorrect because vitamin A is also fat soluble, so deficiencies can occur in severe fat malabsorption. However, the characteristic features of deficiency are night blindness, dry conjunctiva, and keratinization of the cornea, and not nystagmus. So this is not an expected complication of untreated celiac disease. And option E is incorrect because vitamin C is a water-soluble vitamin absorbed in the small intestine, but its absorption is not significantly impaired in celiac disease. Deficiency of vitamin C presents with petechiae, gum bleeding, and perifollicular hemorrhages, but this is not a complication linked to celiac disease. A 39-year-old man presents to the emergency department with sudden onset severe upper abdominal pain that began after a heavy meal. The pain radiates to his back and is associated with repeated non-bloody vomiting. He has a long-standing history of heavy alcohol use and occasional use of NSAIDs. On examination, his temperature is 38.1 degrees Celsius, his pulse is 118, and blood pressure is 95/54. The abdomen is diffusely tender with guarding and rebound. Laboratory studies show normal serum amylase and lipase levels. A chest radiograph is obtained and shown in the figure. What is the most likely diagnosis? Now in the chest radiograph, the arrow pointing here is pointing towards air under the diaphragm, which is a characteristic finding of one condition. The options given here are A. Ascending cholangitis, B. Bilateral pulmonary edema, C. Decompensated liver failure with ascites, D. Pancreatitis, E. Perforated duodenal ulcer. The correct option would be E. Perforated duodenal ulcer, and that is because severe epigastric pain radiating to the back, peritoneal signs of a rigid abdomen and rebound tenderness, and free air under the diaphragm on X-ray strongly suggest a perforated duodenal ulcer. The key radiographic feature here is air beneath the diaphragm, which indicates there is a hollow viscous perforation. Let's have a look at why the other options are incorrect. Option A is incorrect because ascending cholangitis presents with the Charcot triad, which is fever, jaundice, and right upper quadrant pain. Hypotension and confusion may be present in severe cases, but this patient has no jaundice, and cholangitis does not cause pneumoperitoneum, which is air under the diaphragm. And option B is incorrect because in pulmonary edema, there should be bilateral infiltrates and fluid overload signs on chest imaging. The key radiographic feature here in this question is air beneath the diaphragm, which indicates hollow viscous perforation and not lung pathology. And option C is incorrect because liver failure may cause ascites, encephalopathy, and coagulopathy. However, it does not come with free air under the diaphragm. The acute abdominal pain and rigid abdomen point away from this diagnosis. And option D is incorrect because pancreatitis also causes severe epigastric pain radiating to the back, often in alcoholics. However, it is usually accompanied by elevated amylase and lipase, and it does not cause pneumoperitoneum.